Good evening, everyone. So, after a long period of time, I want to put my video on my YouTube channel that is on the topic selective serotonin reuptake inhibitors, that is SSRIs. And before I start my video, I want to request you, if you like this video and if it is useful to you, and if it is helpful to you, kindly subscribe to my YouTube channel. It is Dr. Nitika Pharmacology Discussion. And now I'm going to start with you on the topic selective serotonin reuptake inhibitors, which is the class of drugs used in the treatment of mild to moderate depression. So, history, what is the history of this selective serotonin reuptake inhibitors? It was first started with the introduction of fluoxetine attitude about pharmacological treatment changed because of better tolerance than existing treatments. Simplicity of dosing. Dose was simple and it was having the better tolerance than the existing treatment. Existing treatment at that time was MAO inhibitors and TCAs, that is tricyclic antidepressants. It was better tolerable and it was having simpler doser. Fluoxetine was the first compound which was discovered and it was the having better tolerability and simple dosing as compared to the existing treatment. And other SSRIs were introduced in fluoxetine. It was introduced in 1988, sertraline in 1992. Paroxetine, which is another SSRI, is introduced in 1993. Fluvoxamine in 1994. Citalopram in 1998, escitalopram in 2002. So this is the year of their introduction in history. Now, chemical structure, these are structurally unrelated, and this may account for the differential response we see in some patients with one antidepressant versus another. Means as the structure is different, so the response in different individuals will be different. Rationale for differential response may be related to different morphology of serotonin transport protein. Means there is different morphology of serotonin transport protein, so that will lead to difference in the response in different individuals. So this is the structure of various SSRIs: citalopram, fluvoxamine, sertraline, fluoxetine, paroxetine. Now, pharmacokinetics. Absorption, it is absorbed orally and have peak effects in the range of 3 to 8 hours. Means it will be taken orally and it will be peak effects will be produced in 3 to 8 hours. Absorption of sertraline may be slightly increased by food. Distribution differences in plasma protein binding percentages, with sertraline, fluoxetine, and paroxetine most highly bound, and escitalopram is least bound. So, sertraline, fluoxetine, and paroxetine, it is highly plasma protein bound, and escitalopram is least plasma protein bound. So, these are metabolized in the liver by cytochrome P450 enzymes, and they have a wide therapeutic index. TCAs, they have the negative role, that is, they are having the narrow therapeutic index, narrow therapeutic safety margin. But the SSRIs, they have wide therapeutic index, so their concentration not affected by other drugs, but potential for slowing or blocking the metabolism of many drugs, as they are the enzyme inhibitors. So they increase the levels of various drugs in the body, means they slow or block the metabolism of many drugs. Elimination, so half-life of fluoxetine. Fluoxetine is the shortest acting drug. Its half-life is 4 to 6 days. Then norfloxacin, which is its active metabolite, its half-life is 7 to 9 days. Means the half-life is increased when it is converted to norfloxacin. Citalopram, sorry, it is the longest acting. Fluoxetine is the longest acting, and it is the norfloxacin is again the more longer acting than fluoxetine. And least or the shortest acting is the fluvoxamine, which is 15 hours. Citalopram is 35 hours, escitalopram 27 to 32 hours, sertraline 26 hours, paroxetine 21 hours, and fluvoxamine, which is the shortest acting SSRI, its half-life is the 15 hours. Now, serotonin, something about serotonin. Serotonin is the hormone which is present in digestive tract, in pineal gland, in platelets. It is responsible for platelet aggregation. In digestive tract, it is acting as the prokinetic, so it will lead to nausea, vomiting, diarrhea. Brain, it is the neurotransmitter. It leads to uh, it transmits electrical impulses from one nerve to the next. It acts as the neurotransmitter. The role in depression is it regulates many functions of body and brain. It elevates the mood of the patient. It causes insomnia. It is appetite suppressant. It 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 causes anorgasmia, or it delays the ejaculation. And cognition is it is effective in cognitive functions also. Serotonin deficiency can cause the depressive symptoms. Levels can be decreased due to decreased production in brain cells, decrease in the number of receptor sites, inability to bind properly with receptor sites, shortage of precursor chemical tryptophan. Means there can be shortage of precursor chemical tryptophan, decrease in the brain cells, production in the brain cells, decrease number of receptor sites, inability to bind properly with receptor sites. So SSRIs treat this deficiency of the serotonin. SSRIs, the full form is serotonin selective reuptake inhibitor. These are described as selective because they affect only the reuptake pumps responsible for serotonin, as opposed to earlier antidepressants which affect other monoamine neurotransmitters as well, like histamine, acetylcholine, noradrenaline. Because of this, SSRIs lack some of the side effects of the more general drugs like TCAs. They're having anticholinergic, antihistaminergic, anti-adrenergic effects. But SSRIs, these are not having the anti-adrenergic, antihistaminic, anti-cholinergic effects. So they do not cause the sedation, they do not cause the postural hypotension, they do not cause the arrhythmias, and they do not cause dry mouth, blurring of vision, urinary retention, constipation, and bronchoconstriction. Means they do not cause SSRIs. So this is the mechanism of action. Depression. In the depression, there is serotonin decrease in the presynaptic somatodendritic areas as well as in the synapse. So there is decreased neuronal firing rate, and so then there will be upregulation of pre and post synaptic receptors because serotonin levels decrease in depression. So when we give the SSRIs, selective serotonin reuptake is blocked. Selective serotonin reuptake is inhibited. So serotonin rises in the synapse as well as in the somatodendritic area, and which can result in the acute side effects like in limbic cortex, which affects the 5-HT2A and 2C. There can be anxiety, there can be panic attacks because of acute side effects when the serotonin rises. And this is the short-term effect. Basal ganglia 5-HT2A can cause tremors, rigidity, dystonia, mild Parkinsonism-like symptoms will come. Brainstem sleep center, it can cause insomnia, nocturnal awakening, myoclonus. In spinal cord, it can cause sexual dysfunction. In hypothalamus brainstem, that is in the CTZ 5-HT2, 5-HT3 serotonin receptor neurotransmitter, it can cause nausea, vomiting. And 5-HT3 and 4 stimulation can lead to GIT, mortality increase, and diarrhea. So these are all the acute side effects which come when the levels of serotonin in the body it gets increased. Now, serotonin accumulation in somatodendritic area will increase. That will lead to down regulation of the somatodendritic 5-HT1A autoreceptors. So there will be over time 5-HT1A autoreceptors, they get desensitized. So serotonin neuron is therefore disinhibited. So when the serotonin neuron is disinhibited, when the 5-HT2 receptors, which are 5-HT1A receptors, which is responsible for inhibition of release of the serotonin. So when they are desensitized, there will be increased serotonin release at the axon, causes postsynaptic receptors downregulation. Now, increased serotonin release at the axon that can lead to treatment of depression. And when there is increased release of serotonin at the axon, the postsynaptic receptors downregulation will occur, and that will reduce the side effects of the serotonin. So after some time, the side effects they disappear. So hence this explains early emergence of side effects with SSRIs, delayed therapeutic actions of SSRIs, reduction of as side effects of tolerance as tolerance develops. Reduction of side effects as tolerance develops. So this is how there is because of the down regulation, desensitization of the receptors, there's delayed therapeutic action, and by there's early emergence of side effects because the serotonin levels increase in the brainstem area and the limbic cortex area and the basal ganglia area, resulting in various side effects. So indications, it is given in the depression, fluvoxamine. It has been used as the drug for depression. That comparison has not revealed anyone or to be superior to others. However, considerable diversity is seen in response to various SSRIs among individuals. Hence, in non-responders, before shifting to other classes of antidepressants, it is most reasonable to try other agents in SSRI class. Means direct comparison has not revealed that any of the SSRI is superior to any other, but considerable diversity is seen in response to various SSRIs among the individuals. Suicide, few patients become anxious, they become anxiety is there, there's agitation, hyperarousability is there on starting SSRIs. These symptoms can conceivably provoke or aggravate suicidal ideation, and thus should be closely monitored during the period of maximal risk, that is the first few days and weeks they are taking SSRIs. Means early period, they should be very careful that there is no suicidal ideation developed in the patient. And other indications are anxiety disorders like obsessive compulsive disorders. In adults, the drugs given are fluvoxamine, paroxetine, sertraline, paroxetine, pediatric fluvoxamine, sertraline. SSRI dosages for OCD may need to be higher than those required to treat depression. So, what is the OCD spectrum? Non-suicidal self-mutilation like trichotillomania, nose picking, eyebrow picking, nail biting, compulsive shopping, compulsive gambling, hypochondriasis, body dysmorphic disorder. Panic disorder, with or without agoraphobia, paroxetine and sertraline are the drugs of choice. Social anxiety disorder, benzodiazepines and MAO inhibitors are the drug of choice. Post-traumatic stress disorder, SSRIs both can be used and benzodiazepines can be used. Generalized anxiety disorder, SSRIs. In specific phobias, generalized anxiety disorders, and separation anxiety disorder. Bulimia nervosa, when the patient is eating very uncontrollably, and like fluoxetine can be given 60 milligram per day. Anorexia, when there is loss of appetite, fluoxetine can be given to treat comorbid mood disturbances and obsessive compulsive symptoms. Obesity, fluoxetine. Premenstrual dysmorphic disorder, we can give sertraline, fluvoxamine, fluoxetine, and paroxetine. Now, what are the off-label uses of the SSRIs? They delay the ejaculation, so they can be used in premature ejaculation. Paraphilias. They can reduce obsessive compulsive behavior in people with paraphilias. Autism, sertraline and fluvoxamine. It can be shown to mitigate aggressiveness, self-injurious behavior, repetitive behaviors, some degree of language delay, rarely, lack of social relatedness in adults with autistic spectrum disorders. Fluoxetine has been reported to be effective for features of autism in children, adolescents, and adults. Now, in special population in pregnancy and postpartum, SSRIs comes in category C, but paroxetine it is contraindicated in pregnancy because it causes serious defects. So it comes under the category D. Breastfeeding sertraline is the drug of choice, followed by paroxetine. Geriatric patients, safe and well tolerated because there is no anti-adrenergic, anticholinergic, anti-histaminergic, anti-cardiotoxic effects. Paroxetine may have some anticholinergic activity. Pediatric, only fluoxetine has FDA approval. Renal impairment, no agent clearly preferred to another. However, citalopram and sertraline are suggested as reasonable choices. Hepatic impairment, fluoxetine to be avoided. Citalopram and escitalopram have minimal effects on hepatic enzymes, so they are SSRIs of choice. In diabetes mellitus, fluoxetine, it has been shown to improve the HbA1c levels, reduce insulin requirements, weight loss, enhance insulin sensitivity. So fluoxetine is used in diabetes mellitus patients. Cardiac disorders, sertraline is recommended. Other are also to be likely to be safe, minimal effect on heart rate, minimal effect on blood pressure, no effect on QTc interval. Post-stroke depression, fluoxetine, citalopram. These are the most studied and seem to be effective and safe and widely recommended for post-stroke depression. Parkinson's, motor symptoms may be worsened, low risk, when we use the SSRIs and silegerin, they cause the risk of serotonin syndrome. And serotonin syndrome, there is uh, myoclonus, hyperthermia, rigidity, tremors, seizures, cardiovascular collapse, when levels of serotonin in the body increases. Cancer patients, sertraline and escitalopram are preferred due to least risk of drug interaction. Adverse effects, now adverse effects they cause I've already discussed the adverse effects. They cause nausea, vomiting, diarrhea. They cause sexual dysfunction. They cause anorgasmia, and they cause the delayed ejaculation. And cyproheptadine can be used to treat the anorgasmia and delayed ejaculation. Sildenafil can also be given. Gastrointestinal adverse effects, nausea, vomiting, flatulence, dyspepsia can occur. Sertraline and fluoxetine, the most intense GI symptoms are produced by sertraline and fluvoxamine. Paroxetine can cause weight gain. Headaches can be caused. Fluoxetine is a drug which is likely to cause headache. Central nervous system, they can cause insomnia, sedation, yawning. Anxiety is caused by fluoxetine and sertraline, and least common with paroxetine and escitalopram. Insomnia can be caused by fluoxetine. Sertraline and fluoxetine can cause insomnia. Citalopram and paroxetine can cause some somnolence. Emotional blunting, seizures, extrapyramidal side effects. Anticholinergic effects are not seen so much, but paroxetine have the mild anticholinergic activity also. Hematological adverse effects can be seen. There can be platelet aggregation. Electrolyte and glucose disturbances can occur. They decrease the glucose. Endocrine and allergic reactions decrease prolactin levels, so they can cause galactorrhea. And they can also cause the drug-related rashes. Now, serotonin syndrome is when the levels of serotonin in the body increases. When we give MAO inhibitors in contact with SSRIs, we can give pethidine, we give linezolid, we give dextromethorphan, lithium, L-tryptophan. When we give with the SSRIs, the levels of serotonin increases, which leads to agitation, hyperreflexia, autonomic instability, diarrhea, restlessness, seizures, hyperthermia, myoclonus, rigidity, delirium, coma, cardiovascular collapse, and death. So, to treat the seizures and myoclonus, we have benzodiazepines. To treat the rigidity, hyperthermia, dantrolene, chlorpromazine, anticonvulsants can be given, mechanical ventilation can be done, and paralyze, paralyzing agents can be used. Cyproheptadine, which is the 5-HT2C antagonist, and methotrexate, which is also 5-HT2C antagonist, can be given to treat the symptoms of serotonin. Now, discontinuation syndrome is when we, after a short period of time, when we stop giving the drug. Abrupt withdrawal of SSRIs, especially those with shorter half-life, means like venlafaxine and SNRI and paroxetine and fluvoxamine, which have a shorter half-life. When we stop giving this drug, there is the discontinuation syndrome may develop, which is given by the mnemonic Finnish F for flu-like syndrome, I for insomnia, N for nausea, vomiting, I for irritability or yeah, instability, S for sensory disturbances, H for hyperthermia or hyperarousal. Hyperarousal can lead to, there can be seizures can occur, dizziness, weakness, agitation, hyperarousal, irritability, flu-like symptoms, nervousness, poor concentration, rebound depression does not appear until at least 6 weeks of treatment. It doesn't appear if we give the treatment just for 6 weeks, but when we increase the dose after, when we give stop after 6 weeks, then it appears and usually resolves spontaneously in 3 weeks. So this is the pharmaceutical forms of various drugs, brand names. Half-lives I already discussed with you. Time to steady state and recommended doses. These are most of the side effects, common side effects and the least common side effects of various drugs like fluoxetine, citalopram, escitalopram, paroxetine, fluvoxamine, sertraline. What is their side effects mostly? Common side effects I've already discussed with you. These are all common are there. Now, drug-drug interactions. So they have the fluvoxamine, which is the shortest acting. It has the more predictability to have the drug-drug interactions, followed by fluoxetine, paroxetine, sertraline, citalopram, and escitalopram. So they have the enzyme inhibitory effects. They inhibit the metabolism. So they increase, paroxetine increases risperidone levels, fluoxetine increases buspirone levels, and fluvoxamine increases olanzapine levels when given together. So that's all with SSRIs. I hope you like this video and it is helpful to you and useful to you. Thank you. If you like this video, kindly subscribe to my YouTube channel. It's Dr. Nitika Pharmacology Discussion. Thank you. Be happy, be healthy, be safe, be blessed. Thank you.